Welcome to the deep dive. Today we're pulling back the curtain on a microscopic world, but one that has this massive, sometimes pretty frightening impact on human health. The realm of staphylococcal infections.
It's a really fascinating area.
Yeah, and we've got a really robust set of materials today. We're going to zero in on what the experts call Chapter 147. It's basically a masterclass in understanding these incredibly common and remarkably adaptable bacteria. Our mission for you, our listener, isn't just that you know about staph. We want you to truly master this information. Understand it with the depth and clarity that the elite professionals in this field have.
That's the goal.
We'll extract every crucial detail, connect all those critical dots, and make sure you walk away feeling genuinely well-informed, ready to confidently handle any conversation or concept about staphylococcal infections.
And it's fascinating because, Staphylococcus isn't just another bacterium. It's really a prime example of bacterial versatility. It's constantly adapting, persisting, despite our best efforts to control it. This organism truly embodies that ongoing evolutionary battle in infectious disease. And when we talk about staph, we're not just covering one single type of infection.
No.
We're actually exploring a whole spectrum. It ranges from, relatively minor skin irritations all the way up to severe life-threatening systemic diseases. And these are all driven by incredibly complex, often quite cunning mechanisms within the bacteria themselves.
So to really get a handle on the challenges and complexities staph poses, we absolutely have to start right at the beginning, the foundation. What are these organisms fundamentally, and how do scientists even start sorting through them, categorizing them?
Good place to start.
Let's begin with the most infamous player, Staphylococcus aureus, often just called S. aureus. This species is, pretty much universally recognized as the most virulent among the, more than 40 identified staph species.
Yeah, it's the main one people think of.
It's often described as a pluripotent pathogen. Now, what does that really mean? Think of it like a master craftsman with a full toolkit. S. aureus is just incredibly versatile. It can cause disease through a whole bunch of pathways, sometimes by directly damaging cells with the toxins it makes, and other times through, non-toxin mechanisms.
Right, it has multiple ways to attack.
Its reach is vast. It's responsible for a significant number of infections people get in healthcare settings, those nosocomial infections, but also increasingly common community-based infections.
That's a key shift we've seen.
Yeah, and these can be relatively mild, like simple skin and soft tissue infections, SSTIs we call them, or they can be severe systemic infections impacting vital organs, really threatening life. But alongside S. aureus, there's this large group, often called the other Staphylococci.
The NSaS group.
Exactly. They're frequently grouped as coagulase-negative Staphylococci, or NSaS. Now, while they are generally less virulent than their more aggressive cousin S. aureus, it'd be a huge mistake to just write them off.
Absolutely not. Underestimate them at your peril, really.
They're actually incredibly important pathogens in very specific situations, playing a crucial role, especially in infections involving prosthetic devices, things implanted in the body. So maybe they don't make the headlines as often, but their impact in certain medical contexts is, profound.
And building on that, understanding the basic biology of these bacteria is absolutely foundational. It helps us comprehend why they behave the way they do and why they remain such persistent and, frankly, adaptable threats.
Okay, so break down the biology for us.
All right. Staphylococci are classified as gram-positive cocci. So if you were to look at them under a microscope after doing a special stain, the gram stain, they'd show up purple and perfectly spherical, like little balls.
Okay.
What really helps microbiologists spot them quickly is their distinctive arrangement. They tend to clump together in these irregular grape-like clusters. Imagine looking at a tiny bunch of grapes under high power. That's often what you see.
Grape-like clusters, got it.
And these organisms are minuscule, truly, typically only about 1 micrometer in diameter. Tiny.
Wow.
Beyond just how they look, they have several critical biochemical characteristics that help us tell them apart. For instance, they're catalase positive. This is a key test because it immediately separates them from streptococcal species, another common group of spherical bacteria, which are catalase negative.
So that's a major dividing line right there.
Exactly. Staphylococci are also non-modal, meaning they can't move around on their own. They don't have flagella to swim. Environmentally, they're quite flexible. They're primarily aerobic, so they like oxygen, but they're also facultatively anaerobic, meaning they can switch gears, they can survive and grow even in environments without oxygen. This metabolic flexibility is a huge part of their resilience. They are capable of prolonged survival on environmental surfaces under varying conditions.
Which explains why they're everywhere, right? Hospitals, doorknobs.
Precisely. That's a major factor in their widespread presence and how easily they can be transmitted. And their host range varies too. Some species, like S. aureus, are quite adaptable. They can infect a broad range of hosts, mammals, birds. Others have a much narrower range, maybe limited to just one or two closely related animals. So there's diversity even there.
That's fascinating how just one test, catalase, can split them off from a whole other group.
Yeah.
But what about telling the staff apart from each other? How do we distinguish these tiny culprits in the lab when they might look pretty similar initially?
Right. That's where their unique biochemical signatures come in. Historically, S. aureus was generally distinguished from the other staph species because it produces this specific enzyme called coagulase.
Coagulase.
Yeah, and this enzyme does something really unique. It converts fibrinogen, which is a soluble protein in our blood plasma, into fibrin that's the insoluble protein that forms the mesh of a blood clot. So this ability to clot plasma was like the signature move of S. aureus for a long time.
The clot maker.
Exactly. However, as science and our tools got better, we found some important nuances. Turns out there are several of the coagulase-negative staphylococci, like
Wow.
S. pseudointermedius and S. argenteus, that actually are coagulase positive.
Oh, okay. So the old name doesn't quite fit perfectly anymore.
Precisely. That's why the more accurate term, non-S. aureus staphylococci, or NSaS, is now preferred for these other staph species. It acknowledges their diversity beyond just that one enzyme.
Makes sense.
Beyond coagulase, S. aureus has a few other identifying tricks. It ferments mannitol, a type of sugar alcohol, giving it a distinct metabolic fingerprint. It also tests positive for protein A, a unique surface protein, and it produces DNase, an enzyme that breaks down DNA.
A whole chemical profile.
Right. And visually, when you grow it on blood agar plates in the lab, S. aureus typically forms colonies that are distinctly golden in color and show bahemolysis. That means they completely break open the red blood cells in the agar, creating this clear zone around the colony. That golden color and clear halo are classic signs.
Okay, and the NSS?
Most NSaS species, in contrast, usually form small, white, non-hemolytic colonies. Just little white spots, no clearing of the agar. For quick diagnostics in a clinic, they can use latex kits that detect both protein A and clumping factor. These offer a fast way to pick out S. aureus from most other staph.
Super useful for quick answers.
Definitely, speed matters in infections.
So this brings us to a really critical point. How are diagnostics evolving? Especially for tracking outbreaks, we need more precision, right?
Absolutely. Beyond those traditional culture methods, we're seeing cutting-edge techniques really take off. For highly accurate staphylococcal speciation, that's definitively identifying the exact species, a technique called melitoccal is becoming way more common.
Melditov. Sounds intense.
It stands for matrix-assisted laser desorptionization time-of-flight mass spectrometry. Yeah, it's a mouthful. But think of it like a super fast molecular fingerprinting system. It analyzes the unique protein signature of the bacteria, giving rapid and incredibly accurate IDs.
Wow, okay. Faster and more precise.
Exactly. And when it comes to tracking outbreaks, particularly nosocomial outbreaks in hospitals where you suspect multiple infections might have a common source, it's vital to know if different patient samples have the exact same strain.
Right, you need to connect the dots.
Precisely. And for that, molecular typing methods have been invaluable. Things like pulsed field gel electrophoresis or sequence-based techniques like SPA typing analyze the bacterial DNA to find genetic similarities or differences. This lets epidemiologists trace how a specific strain is spreading.
Like genetic detectives.
Kind of, yeah. And more recently, whole genome sequencing has emerged as the gold standard. This gives you the most detailed genetic blueprint possible. Unparalleled precision for tracking outbreaks and understanding those subtle evolutionary relationships between strains over time. It's like having the complete instruction manual for each bacterium.
Incredible detail. So we know what staph looks like, how we ID it. Now let's really unpack the core question. How does S. aureus go from being this common, often harmless resident on our bodies to, well, a dangerous invader? It seems like a master strategy.
It really is. It's about being in the right place and seizing the opportunity.
Let's start with its epidemiology. S. aureus is this fascinating paradox, isn't it? It's both a commensal, living peacefully with us, and an opportunistic pathogen, just waiting for a chance to cause trouble.
Exactly. That dual nature is key.
The stats are pretty striking. Approximately 20–40% of healthy people are colonized with S. aureus at any given time, and a smaller group, maybe 10%, are persistently colonized with the same strain long term. So a lot of us are carrying it without any issues.
That's right. It's part of our normal microbiome for many people.
But certain groups have an elevated colonization rate, making them more likely carriers. This includes people with type 1 diabetes, HIV-infected patients, patients on hemodialysis, injection drug users, and folks with skin damage.
Yes, certain conditions or behaviors increase the risk of carrying it.
And where does it usually hang out? The anterior nares, so nostrils, and the oropharynx, the back of the throat, are really common primary sites. But it also likes the skin, especially if it's damaged, the vagina, axilla, and perineum.
Moist areas often.
And these colonization sites are super important because they serve as potential reservoirs for future infections. The bacteria are just waiting there.
Silently present, yeah, waiting for a breach.
Which brings us to transmission. It's kind of counterintuitive, but most S. aureus infections are basically self-inflicted, aren't they?
In a way, yes. Most individuals who develop S. aureus infections become infected with a strain that is already a part of their own commensal flora.
So the bacteria you already have causes the problem.
Often, yes. The infection typically kicks off when breaches of the skin or mucosal membrane allow S. aureus to initiate infection. Think a simple cut, a scrape, even a surgical incision. It's an open door.
Makes sense.
Person-to-person transmission also happens frequently, mostly through direct personal contact with an infected body site. Less common, but documented, is spread in aerosols of respiratory or nasal secretions from heavily colonized individuals. But that seems pretty rare.
Okay. Now, certain diseases and conditions really ramp up the risk of getting a S. aureus infection, like diabetes.
Yeah, diabetes creates a sort of perfect storm. You have an increased rate of S. aureus colonization, plus the frequent use of injectable insulin, creating entry points, and potentially impaired leukocyte function, weakening the immune response.
A triple threat almost.
Pretty much. And individuals with defects in their polymorphonuclear leukocytes, or PMNs, those are key bacteria fighting white blood cells. They're at much higher risk.
Like who specifically?
This includes neutropenic patients, say those getting chemotherapy, people with genetic conditions like chronic granulomatous disease, Job syndrome, or Chediak-Higashi syndrome. Also, individuals with end-stage renal disease, HIV infection, skin abnormalities, or prosthetic devices are more vulnerable.
And we can't forget its role in hospitals.
Absolutely not. S. aureus is a leading cause of healthcare-associated infections, and critically, it's the most common cause of surgical wound infections. Its presence and opportunistic nature in medical settings are major challenges.
Okay, here's where things got really interesting and frankly a bit scary over the last few decades. The rise of MRSA.
Yeah, that was a huge shift.
We've seen this dramatic change in the epidemiology of infections due to methicillin-resistant S. aureus, MRSA. What's so significant is that MRSA wasn't just a hospital problem anymore.
Exactly. In addition to its major role as a nosocomial pathogen, MRSA has become an established community-based pathogen. It's out there, widespread, causing infections outside of hospitals, schools, sports teams, communities.
We've seen numerous outbreaks of community-associated MRSA, MRSA infections reported globally, haven't we? Both rural and urban settings, just everywhere.
All over the world, yeah.
Yep.
And this trend seems linked to a dramatic increase in MRSA colonization found in the community itself. More people are just carrying it.
And these outbreaks hit really diverse groups. Children, prisoners, athletes, Native Americans, drug users. It cuts across demographics.
It shows how easily it can spread in close contact settings. The common risk factors consistently pop up: poor hygienic conditions, close contact, contaminated material, and damaged skin.
Makes sense. Interestingly, sometimes it's a single MRSA strain causing an outbreak. Other times it's a variety of strains.
Shows its adaptability again. In the U.S., though, one specific clone, strain sequence type 8 USA300, has really been the dominant one driving community outbreaks.
And while most of these MRSA infections are skin things like boils or abscesses.
Right, the majority involve the skin and soft tissue.
The really concerning part is that 5–10% have been invasive and potentially life-threatening. And these aggressive community strains are increasingly showing up in hospitals, too.
Yeah, blurring the lines. And a major worry is their enhanced capacity to cause disease in immunocompetent individuals. Even healthy people can get seriously sick. That's a real game changer.
Absolutely. And if we connect this to the bigger picture, the genome of S. aureus itself provides these critical clues to its success. Why is it such a good pathogen? How does it adapt, especially to our antibiotics?
Right, the genetics must hold the key.
When scientists started mapping the complete genomes of different S. aureus strains, they found some really eye-opening things. Genome revelations, you could call them.
Okay, like what?
First, there's a high degree of nucleotide sequence similarity in the core genomes. The basic operating system is pretty consistent across strains.
The fundamentals are the same.
Right. Second, and this is crucial for adaptability, they discovered the acquisition of a relatively large amount of genetic information by horizontal transfer from other bacterial species.
So they're swapping genes with their neighbors, like trading tools. Exactly. It's a key way bacteria evolve quickly, picking up new tricks like antibiotic resistance or extra virulence factors from their microbial community. And third, they pinpointed these unique pathogenicity or genomic islands.
Islands?
Yeah, they're essentially mobile chunks of DNA, mobile genetic elements that can jump between bacteria. And these islands contain clusters of enterotoxin and exotoxin genes and eat or antimicrobial resistance determinants. They're like prepackaged arsenals.
Wow. Portable weapon systems.
Pretty much. And critically, among the genes found in these islands is MECA. That's the gene responsible for methicillin resistance.
Oh, the big one.
The big one. It codes for that modified protein, PDP2A, that lets the bacteria ignore methicillin in similar antibiotics. These resistance islands have a specific name, Staphylococcal cassette chromosome MEC, or SCC-MEC.
SCC-MEC. Got it.
They come in different types and sizes, roughly 20 to 60 kilobases. And importantly, for tracking, different types are linked to different settings. Types 1-3 are traditionally associated with nosocomial MRSA, hospital strains, while types 4-6 have been associated with epidemic CA MRSA strains, the community ones. This genetic fingerprint helps epidemiologists trace them.
So the type of island tells you something about where it likely came from.
Often, yeah. And despite all this potential variation, it's remarkable that a relatively limited number of MRSA clones have been responsible for most infections worldwide, both community and hospital. When scientists compared these successful clones to older ones, they found the significant preservation of the nucleotide sequence over time in their core genes.
They stuck with a winning formula.
It suggests exactly that these strains have genetic features, determinants that facilitate survival and spread, contributing to their long-term success and dominance. They found a blueprint that works really well.
Okay, so they have these genes, these mobile islands. What does this actually mean for how they cause disease? It's clearly not just random chance. It sounds like a highly coordinated attack.
It really is. And that level of coordination, that strategic invasion, is largely thanks to the regulation of virulence gene expression.
Ah, the control systems.
Precisely. In both the toxin-mediated diseases and the non-toxin ones S. aureus causes, producing the virulence factors, the weapons, is far from random. It depends on a series of regulatory genes. Key examples are AGRA, accessory gene regulator, and SAR, staphylococcal accessory regulator.
Booster switches.
Think of them like that. Yeah. They don't act alone. They coordinately control the expression of many virulence genes, turning different sets of weapons on or off at different times.
Like how do they know when?
That's the really smart part. The system senses and responds to bacterial density. It's called quorum sensing. The bacteria can essentially talk to each other, figure out how many of them there are.
Wait, they count themselves?
Effectively, yes. Only when they reach a certain population size, quorum, do they decide to unleash their main arsenal. This coordination also dictates the timing. For instance, staphylococcal surface proteins, which are needed for sticking, are synthesized during the bacterial exponential growth phase, when they're rapidly multiplying and trying to get established.
Makes sense. You need glue first.
Right. But then, many secreted proteins, like agatoxin, the enterotoxins, and various enzymes, the stuff that causes widespread damage, are released during the post-exponential growth phase, after they're established, in response to a molecule called RNAi-Phe, which is controlled by agar.
So they stick first, then attack hard. Tactical.
Very tactical. And these regulatory genes seem to work similarly in vivo, inside us. Successful invasion requires the sequential expression of these elements. First, bacterial adhesins are needed to initiate colonization. Then, the subsequent release of various enzymes enables the colony to obtain nutritional support and permits bacteria to spread.
And we know these regulators are important
because studies with strains in which these regulatory genes are inactivated show reduced virulence in several animal models. Take away their command and control, and they're much less effective invaders. It's like disarming the orchestrator.
Wow, okay, that's sophisticated. So this leads to the next big question. How does S. aureus actually navigate the host environment? It's complex, hostile in there. How does it establish itself, spread, and crucially, how does it dodge our immune system?
To successfully investigate and cause infection, there's this remarkably orchestrated sequence of steps usually involved.
A playbook for invasion?
You could call it that. It generally involves contamination and colonization of host tissue surfaces, then a breach of cutaneous or mucosal barriers, followed by establishment of a localized infection, then invasion, crucial evasion of the host response, and finally, potentially metastatic spread to other parts of the body.
A multi-stage assault.
Exactly. Strains already colonizing us, or those we pick up, get introduced into damaged skin, a wound, or the bloodstream. And frustratingly, recurrences of S. aureus infections are common. This is attributed to their capacity to persist in a quiescent state in various tissues, like they go dormant, hiding, waiting to reactivate.
Persistent little bugs. Let's break down those steps. Colonization first.
Right. Colonization of body surfaces. The anterior nares, nostrils, and oropharynx, back of the throat, are very common primary sites. In the nose, it seems to involve attachment of S. aureus to keratinized epithelial cells, sticking to the lining. Whether colonization takes hold depends on things like the influence of other resident nasal flora, basically the neighborhood bacteria, host factors, and any nasal mucosal damage, say, from drug use.
And other spots are reservoirs too, especially for CA-MRSA.
Yes, damaged skin, the groin, and the oropharynx seem particularly important reservoirs for CA-MRSA strains, critical staging grounds.
Okay, stage 2, inoculation and colonization of tissue surfaces. How do they get deeper?
Through things like minor abrasions, even a mosquito bite, or medication injections like insulin or IV catheters. Once they're in, they replicate and colonize. A key tool here is that family of surface proteins called MS-grams.
Microbial surface components recognizing adhesive matrix molecules.
Yeah.
Got it memorized, maybe.
Yeah, it's a mouthful. But these MS-grams are crucial mediators of adherence. Specific ones like clumping factor and collagen-binding protein help the bacteria stick to exposed matrix molecules like fibrinogen, collagen, or fibronectin stuff in our tissues or clots. The sticking ability is critical for invasive infections like endocarditis, sticking to art valves, or septic arthritis in joints.
And biofilms. I thought that was more the NSaS thing.
While NSaS are famous for biofilms on devices, it's crucial to know that S. aureus also possesses the genes responsible for biofilm formation, like the Etiology. Biofilm formation on devices is a stepwise process. First, staphylococcal adherence to serum constituents that have coated the device surface using our proteins as glue, and subsequent biofilm elaboration, building that protective matrix. This makes S. aureus a frequent cause of biomedical device-related infections, a huge problem.
Okay, so they stick, they build shields, then invasion and local spread.
Right. At the infection site, they replicate and start pumping out a diverse array of enzymes. Serine proteases, hyaluronidases, thermonucleases, lipases. These aren't random. They facilitate bacterial survival and local spread. For instance, lipases may facilitate survival in lipid-rich areas such as the hair follicles, which is exactly where boils often start.
Breaking down barriers and grabbing resources. Now, the really sneaky part, evasion of host defense mechanisms. How do they fight back against our immune system?
They have a whole arsenal. The staphylococcal cell wall itself is a weapon. Its components can cause pore formation in various eukaryotic cells, punching holes in our cells, and can also initiate a strong inflammatory response, sometimes mimicking sepsis.
Just the wall itself is dangerous.
Yes. Then there's the notorious pentanvalentine leukocidin, or PVL. This toxin is cytolytic to PMNs, macrophages, and monocytes. It kills key immune cells. Strains making PVL are linked with nasty, cutaneous, and more serious infections like severe pneumonia, especially with CA-MRSA.
Taking out the defenders.
Exactly. They also have an antiphagocytic polysaccharide microcapsule. Think of it as a slimy invisibility cloak that helps them avoid being eaten by immune cells. It works so well that most human S. aureus infections are due to strains with capsular types 5 and 8. And this capsule also helps induce abscess formation, walling off the infection site.
A protective capsule, and it helps build abscesses.
Wow. And there's protein A, unique to S. aureus. It acts as an FC receptor binding to our IgG antibodies, but in a way that prevents opsonophagocytosis by PMNs, disabling a key immune clearance mechanism.
So it turns our own antibodies against us in a way.
Effectively, yes, it blocks their function. They also have proteins like CHIPS and EAP that interfere with PMN migration, putting up roadblocks so immune cells can't even reach the infection. Plus, they produce cytolytic toxins, including a toxin and Panton-Valentine toxin, that directly lease host cells, causing tissue damage.
Roadblocks, toxins, disabling antibodies. Quite the toolkit.
And there's more. An additional potential mechanism is its remarkable capacity for intracellular survival. They can hide inside our own cells.
Inside. Like a Trojan horse.
Sort of. Both professional phagocytes, like macrophages, and even non-professional phagocytes, like endothelial cells, can internalize staphylococci. This may provide a sanctuary, protecting them from defenses outside the cell. This seems especially relevant for liver cells, Kupffer cells, during bloodstream infections.
Hiding out in the liver.
And inside cells, they can sometimes switch to become small colony variants. These are often seen in patients on certain antibiotics or with cystic fibrosis or osteomyelitis. These variants facilitate prolonged staphylococcal survival and enhance the likelihood of recurrences.
Explains why some infections just keep coming back.
It's a major factor. And one last trick. X. aureus can survive within PMNs, are primary defenders, and may even use these cells to spread and seed other tissue sites, hitching a ride inside the enemy.
That is incredibly devious. So, focusing on CA-MRSA specifically, what makes them extra virulent?
Right. The pathogenesis of CA-MRSA infections. Certain factors contribute to their enhanced virulence. We mentioned PVL earlier. There's that strong epidemiologic association between the PVL gene and severe SSTIs and with necrotizing post-influenza pneumonia.
A lung-destroying kind.
Exactly. Other key determinants in CA-MRSA include the arginine catabolic mobile element, ACME, a gene cluster that might help evade host defenses, phenol-soluble modulins, a family of cell-damaging peptides, and the potent toxin. Together, these make CA-MRSA particularly nasty, even for healthy people.
And how does our body try to fight back?
Yeah.
The host response.
The primary response is the recruitment of PMNs, the neutrophils. They're attracted by bacterial components and by cytokines like TNF and interleukins released by our own activated cells. Now, while most individuals have antibodies to Staphylococci from past encounters, it's not clear that antibody levels are qualitatively or quantitatively sufficient to protect against infection.
So having antibodies doesn't guarantee protection?
Unfortunately, no. Specific anti-capsular and anti-MS-CRAM antibodies looked promising in the lab and in animals, helping tag bacteria for destruction, but they have not yet successfully prevented staphylococcal infections in clinical trials. Developing an effective vaccine remains a huge challenge.
A persistent challenge indeed. Okay, now that we've got the microscopic battle down, let's zoom out to the actual diseases these bacteria cause. From, like you said, a tiny pimple to a major crisis, S. aureus has this incredibly wide range of clinical effects. Let's start with the pathogenesis of toxin-mediated disease.
Right. S. aureus makes three main types of toxins with different effects. Cytotoxins that kill cells, pyrogenic toxin superantigens that cause that massive immune overreaction, and exfoliative toxins that target the skin.
And for these illnesses, it's really the toxin doing the damage, right? Not necessarily the bacteria spreading everywhere.
Often, yes. Data strongly suggests that antitoxin antibodies are protective against illness in TSS, staph food poisoning, and SSSS, staphylococcal scalded skin syndrome. This tells us the toxin itself is the main culprit. The illness develops after toxin synthesis and absorption and the subsequent toxin-initiated host response. The bacteria just need to produce the toxin. It doesn't even have to be a raging infection sometimes.
Just the toxin getting in is enough.
Exactly, which is why understanding these syndromes is vital for clinicians. It guides diagnosis and treatment. Let's dive into the specific clinical syndromes, starting with the most common. Skin and soft tissue infections, or SSTIs.
What makes someone prone to these?
Several factors. Chronic skin conditions like eczema, any skin damage like bug bites or minor trauma, injections like for diabetes or drug use, and sometimes poor personal hygiene. These infections typically involve formation of pus-containing blisters, often beginning in hair follicles and spreading.
Okay, like what specific types?
Well, you have folliculitis, a superficial infection in the hair follicle. Looks like a little pus-filled bump with redness. Then furuncles, or boils. They're more extensive, painful lesions, often in hairy, moist areas. They go deeper, forming a true abscess with pus.
Okay, boils. Got it.
Carbuncles are even worse. Usually on the lower neck, they're more severe and painful. Basically, multiple boils merging together, extending deep into the tissue. You can often see pus draining from multiple points.
Ouch. Sounds nasty.
They are. Other common ones are impetigo, with those crusted sores, and cellulitis, a spreading skin infection. And remember, S. aureus is a top cause of surgical wound infections. Also, mastitis, breast tissue infection, affects 1–3% of nursing mothers, usually a few weeks after delivery, sometimes with fever and chills.
Moving beyond skin, musculoskeletal infections.
Yes, S. aureus is a major player here too. Osteomyelitis, bone infection, is common. It can happen from hematogenous dissemination, bacteria spreading through the blood, or contiguous spread from nearby infected tissue.
How does it present differently in kids versus adults?
In kids, hematogenous osteomyelitis most often involves the long bones, like the femur. Symptoms are usually fever and bone pain, or maybe the child just refuses to bear weight. Labs often show inflammation. Blood cultures are positive maybe half the time. Bone biopsy is usually diagnostic if needed.
An adult.
In adults, long bone osteo is less common. But vertebral osteomyelitis, infection of the spine, is more frequent. We see it in patients with endocarditis, those on hemodialysis, diabetics, injection drug users. It can cause intense back pain and fever, but sometimes it's subtle, just chronic back pain and low fever, making it tricky to diagnose.
And related to the spine, epidural abscesses.
Yes. S. aureus is the most common cause of epidural abscess, a collection of pus near the spinal cord. It's a medical emergency because it can quickly cause spinal cord compression and nerve pain.
How do you diagnose these bone infections?
MRI is the most reliable imaging modality. X-rays are often done first, but they can look normal for up to 2 weeks, so they can miss early infections. CT is an alternative to MRI. For infections spreading from nearby tissue like diabetic ulcers, signs include exposure of bone, a draining fistulous tract, failure to heal, or continued drainage. Diagnosis is confirmed by bone culture and histopathologic examination showing infection. Surgical samples are best for culture. MRI helps distinguish bone from just soft tissue infection.
Okay, what about septic arthritis, joint infections?
S. aureus is the most common cause in native joints for kids and adults. It's rapidly progressive and may cause extensive joint destruction if not treated quickly. Presents with intense pain on moving the joint, swelling, and fever. Aspirating the joint fluid usually shows cloudy fluid packed with white blood cells, PMNs, and you often see the bacteria on gram stain. In adults, it can follow trauma, surgery, or spread through the blood, often affecting knees, shoulders, hips. It likes joints already damaged by arthritis, and sometimes medical procedures themselves cause it.
And pyomyositis, muscle infection.
Yeah, pyomyositis is an unusual infection of skeletal muscles. More common in the tropics, but also seen in immunocompromised people. You get localized pain, tenderness, swelling, heat. Aspirating the muscle yields pus. Its exact cause is poorly understood.
Okay, shifting to respiratory tract infections.
In newborns and infants, S. aureus can cause serious respiratory infections with shortness of breath, fever, respiratory failure. Chest x-rays might show pneumatoceles, those thin-walled cavities. Complications like collapsed lung, pneumothorax, or pus in the chest cavity, empyema, can happen.
And in adults?
In adults, nosocomial, or hospital-acquired, S. aureus lung infections are common among intubated patients in ICUs. Being nasally colonized increases risk. The presentation looks like other bacterial pneumonias.
What about community-acquired?
Often follows viral infections, most commonly influenza. That's a classic setup. Patients might have fever, bloody sputum, and those pneumatoceles or multiple patchy pulmonary infiltrates on imaging. Diagnosis usually comes from sputum analysis. Blood cultures are often negative here.
Now for the really scary stuff. Bacteremia, sepsis, and infective endocarditis.
Yeah, this is where S. aureus is particularly dangerous. S. aureus bacteremia, bacteria in the bloodstream, can lead to severe complications like sepsis, endocarditis, heart infection, vasculitis, blood vessel inflammation, or metastatic seeding, where the infection spreads to bones, joints, kidneys, lungs.
How often does it spread like that?
It's estimated as high as 31%, and the risk increases with the duration of the bacteremia. Recognizing these complications just by looking at the patient is challenging. Certain conditions like diabetes, HIV infection, and renal insufficiency increase the risk. Also, getting the infection in the community, not having an obvious source, or having prosthetic devices makes complications more likely.
And sepsis.
Presents similarly to sepsis from other bugs. That progression of low blood pressure, fever, maybe respiratory alkalosis, diagnosis confirmed by positive blood cultures.
Let's focus on infective endocarditis, heart infection.
S. aureus is now the leading cause of endocarditis worldwide, about 25–35%. 10% of cases. The incidence has increased over the past 20 years, largely due to increased use of intravascular devices and the tragic upsurge in injection drug use.
So catheters and drug use are major drivers.
Big time. About a quarter of patients with catheter-associated S. aureus bacteremia get endocarditis. Other risks include hemodialysis, having intravascular devices during bacteremia, immunosuppression, and having things like pacemakers. Mortality is tragically high, 20 to 40%, despite antibiotics. Complications include leaky valves, clots traveling, emboli, metastatic infection, vasculitis, and dangerous brain involvement like aneurysms or strokes.
You mentioned 4 clinical settings for endocarditis.
Right. First is right-sided endocarditis, classic in injection drug use. Patients often have high fever, look very ill, toxic, have pleuritic chest pain and cough up purulent, sometimes bloody sputum. Imaging shows septic pulmonary emboli, small round lesions in the lungs. Often these patients had normal heart valves before. You need high suspicion.
Okay.
Left-sided native valve endocarditis, usually in people with pre-existing valve damage, often older patients, worse prognosis, more complications.
Right.
Prosthetic valve endocarditis. S. aureus is a common cause. It can be especially fulminant, really aggressive right after surgery. High morbidity mortality, often needs urgent valve replacement, prone to valve leaks or abscesses around the valve.
And fourth.
Nosocomial endocarditis, acquired in the hospital, often linked to intravascular devices. Patients are usually critically ill, already on antibiotics, making diagnosis hard as blood cultures may be negative. Diagnosis can be missed.
How do you diagnose endocarditis generally?
Suspected from history and physical signs, new murmurs, skin signs like Osler's nose or Janeway lesions, evidence of emboli, risk factors. Blood cultures are almost uniformly positive if no prior antibiotics. Echocardiography, especially transesophageal, TEE, helps find vegetations on valves. The Duke criteria are standard diagnostic guidelines.
What about infections on other prosthetic devices?
S. aureus causes a large chunk of these infections: joints, grafts, catheters, pacemakers. Unlike the slow NSaS infections, S. aureus device-related infections are often acute, with local and systemic signs progressing rapidly. Often find pus at the device site. Most occur within a year of implantation unless it's an access device. The key principle: successful therapy usually involves removal of the device. Left in place, it's a constant source for relapse.
And UTIs.
Infrequent cause. If S. aureus is in the urine, it often suggests hematogenous dissemination spread from the blood, meaning you need to look for the primary infection source elsewhere. Rarely it can ascend after urinary tract procedures.
Lastly, those invasive infections associated with community-acquired MRSA.
Right. While SSTIs are most common, remember 5–10% are invasive and can be life-threatening. These include those really nasty things rarely seen before MRSA. Necrotizing fasciitis, flesh-eating, necrotizing pneumonia, and sepsis with Waterhouse-Friderichsen syndrome or purpura fulminans, severe bleeding organ failure. These reflect the increased virulence of MRSA strains.
Truly frightening possibilities.
Yeah.
Okay, let's unpack another crucial angle. Sometimes the main issue isn't the bacteria spreading, but the powerful toxins they pump out, leading to distinct severe illnesses, even without a massive bacterial invasion. Let's hit these toxin-mediated diseases.
Absolutely. First up, food poisoning.
A classic.
Indeed. S. aureus is among the most common causes of foodborne outbreaks in the U.S. It happens when a food handler colonized with a toxin-producing strain contaminates food. The toxin gets produced in growth-promoting food as custards, potato salad, or processed meats.
And the toxin is heat-stable, right? That's key.
Critically important. Even if the bacteria are killed by warming, the heat-stable toxin is not destroyed. Cooking kills the bugs, but not the preformed poison.
Nasty symptoms.
Onset is rapid, occurring within 1 to 6 hours of ingestion. Mainly nausea and vomiting, though diarrhea, low blood pressure, dehydration can occur. You need to differentiate it from other causes of rapid onset diarrhea, like Bacillus cereus toxins.
What are the clues? It's staph.
The rapidity of onset, the typical absence of fever, and often an epidemic nature. Multiple people sick from the same source, with no secondary person-to-person spread. Symptoms usually resolved within 8–10 hours. Short but intense. Diagnosis is confirmed by finding the bacteria or toxin in the food. Treatment: entirely supportive. Fluids, rest.
Okay. Next, toxic shock syndrome, TSS. That got a lot of attention back in the day.
Huge attention. Gained notoriety in the early 80s with that nationwide outbreak associated with the use of a highly absorbent tampon linked to TSST1 toxin. When that tampon was pulled, cases dropped dramatically.
It didn't disappear entirely.
No, both menstrual and non-menstrual cases continue to be reported. Non-menstrual cases often involve surgical or postpartum wound infections, especially when packing occurs, creating an ideal toxin-producing environment. Presentation is similar in both types. And importantly, an active infection isn't required, just toxin production at a colonization site.
Which toxins are involved?
Usually an enterotoxin or the structurally related enterotoxin like TSST1. Over 90% of menstrual cases involve TSST1. A high percentage of non-menstrual cases involve enterotoxins like B.
How does it present clinically?
Starts vaguely. Non-specific flu-like symptoms. Menstrual cases usually start 2-3 days into the period, then rapid onset of fever, hypotension, and that characteristic erythroderma, a widespread red rash. Mucosal involvement like red eyes is common. It can quickly progress to vomiting, diarrhea, confusion, myalgias, abdominal pain, reflecting multisystemic involvement, liver, kidneys, GI tract, CNS.
And that skin peeling later.
Yes. Desquamation of the skin occurs during convalescence, usually 1-2 weeks after onset. Lab findings show kidney stress, azotemia, high white cells, leukocytosis, low albumin, low platelets, abnormal liver function. Diagnosis relies on the constellation of findings and ruling out other things like viral rashes, RMSF, sepsis, Kawasaki. Crucially, illness usually happens only in people who lack antibody to TSST1, and recurrences are possible if antibody fails to develop.
Let's dig into the mechanism of superantigens, like TSST1. Why are they so potent?
It's a fascinating bypass of normal immune activation. Normally, antigens are processed inside cells, peptides presented neatly in the MHC class II groove, triggering a measured T-cell response. Superantigens like TSST1 bind directly to the invariant region of MHC outside the groove. They then bind T-cell receptors via the Vought chain. This abnormal bridging massively overstimulates T-cells, activating up to 20% of the total T-cell population.
20%, that's huge.
Massive. It causes a cytokine storm, a flood of inflammatory mediators like interferon, IL-1, IL-6, TNF-I, TNF-A. This results in the multi-system disease that mimics endotoxin shock, though the mechanism is different. For food poisoning, a different region of the enterotoxin molecule is responsible. It's heat-stable, stimulates the vagus nerve and vomiting center, and increases gut motility.
And the last toxin one, staphylococcal scalded skin syndrome, SSSS.
Right. This primarily affects newborns and children. It can range from a localized blister to exfoliation of much of the skin surface. The skin is usually fragile and often tender with thin-walled, fluid-filled bullae. A key sign is Nikolsky's sign. Gentle pressure makes the top skin layer slide off.
Like peeling wet paper.
Exactly. Importantly, mucous membranes are usually spared. Generalized cases often have constitutional symptoms like fever, lethargy, poor feeding. Significant amounts of fluid can be lost. It usually follows a localized infection somewhere else. Adult cases are less common but can happen. The mechanism involves exfoliative toxins, ETA and ETB. They're serine proteases that cleave desmosomal cadherins, the glue holding skin cells together in the superficial layer, causing that split in the epidermis and the characteristic peeling.
Okay, let's pivot now to the other staph. While S. aureus is the big gun, the non-S. aureus staphylococci, the NSaS, are definitely not minor league players, right? Especially in certain situations.
Absolutely. They are crucial pathogens in specific contexts.
So for a general overview, we know they're less virulent than S. aureus, generally less aggressive, and it's a big game. But they are among the most common causes of prosthetic device infections, including endocarditis.
That's their main claim to fame, unfortunately, and a huge clinical problem.
They're also increasingly a cause of native valve endocarditis and cause life-threatening bloodstream infections in neonates and in neutropenic patients, those with weakened immunity.
Right. They exploit vulnerability. About half the known NSaS species have caused human infections, but the most common pathogen by far is Staphylococcus epidermidis.
It should be everywhere on us, right?
Exactly. It's part of the normal human flora, super abundant on skin, also in the oropharynx and vagina. That ubiquity makes it a prime opportunist. Another key one is Staphylococcus saprophyticus. It's methicillin-resistant and a common pathogen in UTIs, particularly in young women.
And there are a couple of more aggressive NSaS.
Yes, Staphylococcus lugdunensis and Staphylococcus schleiferii. These two cause more serious infections, like native valve endocarditis and osteomyelitis, more similar to S. aureus. Why? They seem to share more virulence determinants with S. aureus, like clumping factor and lipase. They've borrowed some of the bad cousins' tricks. What's really fascinating here is how these supposedly less virulent species, especially S. epidermidis, have evolved these specific, highly effective strategies to thrive in certain niches, particularly around foreign bodies like medical devices. It's remarkable adaptation.
Tell us about the pathogenesis of NSaS, especially S. epi on devices.
Right, for S. epidermidis and prosthetic devices, it's usually a two-step process: initial adhesion, then colonization and biofilm formation. S. epi is uniquely adapted for this because it produces that extracellular polysaccharide, the glycocalyx or slime.
Biofilm component.
Exactly. That slime facilitates formation of a protective biofilm on the device surface. When a device is implanted, it quickly gets coated with our own proteins, like fibrinogen or fibronectin. These act as bridging ligands, helping the bacteria initially attach.
To use our own stuff against us.
Clever, isn't it? Staph surface proteins like ADALE, fibrinogen binding protein, and AAP help with this initial sticking. Then, the polysaccharide intercellular adhesin, produced by the iPA facilitates subsequent colonization, aggregation, and accumulation. Notably, those ICA are more common in S. epidermidis strains linked to device infections.
Proof they're important for causing disease.
Exactly. And that biofilm acts as this incredible barrier protecting bacteria from host defenses as well as from antibiotics. It provides a safe haven for them to mature, survive, and potentially spread. That's why device infections are so hard to clear without removing the device.
And S. saprophyticus in UTIs. How does it stick?
Its ability seems related to specific adhesins that facilitate adherence to uroepithelial cells, the cells lining the urinary tract. A specific 160 kilodalton hemagglutinin adhesin might be involved, helping it bind and resist being flushed out.
Special sticky proteins for the urinary tract.
Okay.
But this leads to a huge diagnostic headache. If these NSaS are all over our skin, how do you know if a positive culture is a real infection or just skin bug contamination?
That is a major challenge in the diagnosis of NS. Detecting them isn't hard, they grow easily in the lab, but interpretation of these results is frequently problematic.
Because they're common contaminants.
Precisely. Because these organisms are present in large numbers on the skin, they often contaminate cultures. The estimate is stark. Only 10–20% of blood cultures positive for NSS reflect true bacteremia.
Wow, 80–90% could be false positives, essentially.
Yeah. From a clinical significance standpoint, yes. Similar issues arise with cultures from other sites, so clinicians have to look for clues for true bacteremia. Obvious clinical signs help. Fever, evidence of local infection like redness or pus at an IV site, leukocytosis, systemic signs of sepsis.
And lab clues.
Key lab findings include repeated isolation of the same strain, meaning the same species with the same antibiotic susceptibility pattern, or confirmed identical by molecular typing, from cultures obtained from different sites or at different times. Like 2 or more blood cultures collected at least 24 hours apart. Also, growth in multiple blood cultures, especially if it grows quickly in both aerobic and anaerobic bottles, suggests a real infection. Consistency is key.
Makes sense. You need multiple lines of evidence. So even if they're less aggressive than S. aureus, how do NSaS infections actually look clinically? What makes them different?
Let's talk clinical syndromes of NSaS. They are a top cause of prosthetic device-related infections: valves, joints, grafts, catheters, shunts. The clinical presentation is often quite subtle.
Slow and sneaky compared to S. aureus.
Often, yes. Signs of localized infection are often subtle, progression is slow, and systemic findings are often limited. You might see some purulent drainage, pain at the site, or loosening of prosthetic implants, but it can be insidious. Fever is frequently, but not always present, maybe mild leukocytosis. Inflammatory markers like ESR and CRP may be elevated, which can be a clue.
What about infections not involving devices?
They cause those too. Native valve endocarditis due to NSaS accounts for about 5% of cases. Infections in preterm infants and neutropenic patients are often linked to IV devices needed for their care. And remember, S. lugdunensis. It's a more aggressive pathogen in endocarditis, causing more mortality and valve destruction, behaving more like S. aureus. A critical distinction.
Definitely need to keep an eye out for that one. All right, we've covered the bugs, the diseases. Let's get to the really critical part, treatment strategies. Once you diagnose a staph infection, what are the core principles, especially with all this resistance floating around?
Okay, general principles of therapy. First and foremost, source control is absolutely key. You cannot overstate its importance.
Meaning get rid of the source of the infection.
Exactly. Things like incision and drainage of suppurative collections, lancing boils, draining abscesses, and very often removal of infected prosthetic devices because antibiotics often can't penetrate those biofilms effectively. This source control must be combined with rapid institution of appropriate antimicrobial therapy. Get the right drug in fast.
And you need to know which drug is right.
Precisely. The emergence of MRSA as a community-based pathogen has increased the importance of culturing all sites of infection in order to determine antimicrobial susceptibility. You absolutely need those susceptibility results to guide treatment effectively and avoid failure. No more guessing.
So, culture, drain, or remove, then targeted antibiotics. Makes sense. Now, what about how long to treat?
Right, the duration of antimicrobial therapy is crucial and depends on the situation. For S. aureus bacteremia, treatment is generally prolonged. 4 to 6 weeks.
4 to 6 weeks. Wow. Why so long?
Because of the high risk of complications, like endocarditis or metastatic infection spreading elsewhere, we define complicated bacteremias by things like persistently positive blood cultures after 96 hours of therapy, getting the infection in the community, failure to remove or drain an identified focus like a catheter, or the presence of deep-seated infections like in bone.
So if any of those are present, you need the long course. What about uncomplicated?
For truly uncomplicated bacteremia is defined by having a removable focus, a prompt response to therapy, no fever-positive cultures after 3 to 4 days, no evidence of metastatic foci, and no implanted prostheses, then maybe short-course therapy, 2 weeks, can be given. But, and this is important, these findings are not always predictive.
So even if it looks uncomplicated, you have to be careful.
Extremely careful. That's why transesophageal echocardiography to rule out endocarditis is generally necessary because clinical signs alone can miss it. And a thorough radiologic investigation to look for hidden metastatic collections is also indicated. You have to check everywhere. A recent positive development is studies showing parenteral therapy, IV antibiotics, is not always necessary to complete a course for things like endocarditis or osteomyelitis. Sometimes you can switch to oral later.
That's a big deal for patients. What about NSaS treatment duration?
It's tricky because of the contaminant issue. But for documented infections like the same strain in blood cultures drawn 24 hours apart, therapy for 7-14 days is recommended if there's no endocarditis or other deep infection.
Okay, now the big one. Choice of antimicrobial agents. This seems really complex with resistance.
It is often difficult because the prevalence of multi-drug resistant strains and the limited number of clinical trials comparing options directly. Resistance to methicillin and glycopeptides like vancomycin has increased steadily. And it's even more apparent with NSaS, where over 80% of hospital isolates are methicillin-resistant and often resistant to many other drugs too.
So what do you use? Let's start with the rare penicillin-susceptible strains.
Right. Few strains, 0.5%, remain susceptible because of widespread penicillinase production. If you do find one, penicillin is great, but usually they're penicillin-resistant. For those, you use semi-synthetic penicillinase-resistant penicillins, SPRPs, like oxacillin or nafcillin. Methicillin itself isn't used anymore.
Alternative.
Cephalosporins work. But second and third generation cephalosporins offer no therapeutic advantage over first generation ones for staph, and some third gens are actually less active. Carbapenems are good for methicillin-sensitive S. aureus, MSSA, but useless against MRSA.
Okay, now for the main event. Methicillin-resistant S. aureus, MRSA, the big challenge.
The big challenge indeed. MRSA popped up within a year of methicillin's introduction back in the 60s. Shows you how fast bacteria adapt. Since then, prevalence has steadily increased. In many U.S. hospitals now, 40–50% of S. aureus isolates are resistant.
And resistance to methicillin means resistance to a lot of other drugs, too.
Yes, it indicates resistance to all SPRPs as well as to all cephalosporins, except for the newer one, ceftaroline. The mechanism is that MECA gene, producing the altered PBP2A protein located on that SCC-MEC mobile element, probably acquired via horizontal transfer.
How do labs detect it? Can be tricky.
It can be. Expression might be constitutive, always on, or heterogeneous, only some cells express it. Detection is sometimes enhanced by growing cultures at lower temperatures or higher salt concentrations. But increasingly, culture techniques are being replaced by PCR-based or other rapid molecular methods for faster, more reliable detection.
So what's the go-to treatment for invasive MRSA?
Either vancomycin or daptomycin are recommended as the drugs of choice. However, vancomycin is facing issues. MRSA susceptibility to vancomycin has decreased in many areas, the MIC group will discuss. And crucially, vancomycin is less effective than SPRPs for exactly. Then you have Visa, vancomycin intermediate S. aureus, first seen in Japan in '97. These strains evolve under vancomycin pressure. The mechanism often involves an abnormally thick cell wall that traps vancomycin, preventing it from reaching its target. Regulatory genes affecting cell wall building are involved.
And VRSA, fully resistant.
VRSA, vancomycin-resistant S. aureus, even rarer, thankfully. First U.S. case in 2002. These acquired the VAN-A gene via conjugation from vancomycin-resistant Enterococcus faecalis. The VAN-A gene changes the drug's target site. Dialidal becomes dialidase, so vancomycin can't bind. While MIC creep is common, true Visa and VRSA isolates are uncommon, but a major threat when they appear. For these, daptomycin or ceftaroline are key options.
Okay, let's run through some other key antibiotics, specific antibiotic profiles. What about daptomycin?
Daptomycin, parenteral bactericidal agent, kills bacteria, given IV air. Approved for bacteremia, including right-sided endocarditis and complicated skin infections. Crucial limitation, not effective in respiratory infections because lung surfactant inactivates it. Unique mechanism disrupts the cytoplasmic membrane. Resistance can emerge during therapy. Need to monitor for muscle breakdown, rhabdomyolysis, and rare eosinophilic pneumonia. Linezolid, first oxazolidinone, bacteriostatic, inhibits growth. Big plus, comparable bioavailability, oral or IV, easy switch. No cross-resistance with other protein synthesis inhibitors, but resistance to linezolid is increasing. Side effects can include low platelets, sometimes low white cells, and rare lactic acidosis or nerve damage, neuropathy with long courses. Tedizolid. Second oxazolidinone or Orevlib. Enhanced in vitro activity against resistant bugs like MRSA. Dosed once daily. Less data for deep-seated infections compared to linezolid. Ceftaroline. Fifth-generation cephalosporin. Notable for bactericidal activity against MRSA, including some strains with reduced vancomycin dapto susceptibility, generally well tolerated, approved for pneumonia and SSTIs, increasingly used off-label for invasive MRSA. Telavancin, parenteral lipoglycopeptide, like a modified vancomycin, approved for complicated SSTIs and hospital pneumonia. Hits two targets, cell wall and cell membrane, active against Visa, potential nephrotoxicity, so avoid in kidney disease.
Dalbavancin and ortavancin. Long-acting parenteral lipoglycopeptides. For complicated SSTIs, super long half-lives allow weekly or even single-dose regimens. Some anecdotal use for invasive infections. Quinolones, like Cipro.
Quinolones. Active in vitro, but frequency of staphylococcal resistance has increased, especially in MRSA. Big concern about resistance emerging during therapy, so generally not recommended for MRSA infections alone. Resistance involves gene mutations or efflux pumps. Delafloxacin is newer, broader, retains activity against some resistant MRSA. Tigecycline, broad spectrum related to minocycline. Bacteriostatic activity against MRSA. Approved for SSTIs, intra-abdominal. Not recommended for invasive infections due to efficacy concerns in bloodstream infections.
What about older drugs? Still useful?
Yes. Other older antibiotics, minocycline, doxycycline, clindamycin, and trimethoprim sulfamethoxyls continue to be successfully used to treat MRSA infections, especially milder ones, or for oral step-down therapy.
Okay. What about anti-staphylococcal combinations, using two drugs at once?
Benefit remains controversial for deep-seated infections. Studies haven't consistently shown adding gentamicin or rifampin improves outcomes over single drugs. Plus, concerns about gentamicin's kidney toxicity and rifampin's side effects interactions. So gentamicin is no longer routinely recommended for things like native valve endocarditis. Rifampin, however, continues to be used for prosthetic device-related infections and for osteomyelitis, likely due to its biofilm penetration.
So putting it all together, how does this apply in specific antimicrobial therapy for selected settings, starting with empirical therapy?
Right, when you don't know susceptibilities yet. Vancomycin or daptomycin are generally recommended for suspected serious MRSA infections. Daptomycin might be preferred if local vancomycin MICs are creeping up.
What about salvage therapy? When the first treatment isn't working, bacteremia persists.
Yeah, when bacteremia lasts more than 3 or 4 days, despite appropriate treatment, the risk of bad outcomes goes way up. Evidence is limited, but some combinations have shown success. Daptomycin or vancomycin with a lactam antibiotic, for example ceftaroline, has worked for persistent MRSA bacteremia.
Why does that combo work?
The theory for daptomycin synergy is the beta-lactam alters the cell surface charge, allowing better daptomycin binding. For vancomycin, it might allow better access to the target site. Other options tried include adding trimethoprim sulfamethoxazole or rifampin to daptomycin, or using linezolid or ceftaroline alone as alternatives.
Okay. Endocarditis.
Acute, life-threatening. Get blood cultures, then start empirical therapy immediately. For native valve MSSA, a beta-lactam. For MRSA, vancomycin or daptomycin. Treat for 6 weeks generally. For prosthetic valves, surgery in addition to antibiotic therapy is often necessary. The combo is often a beta-lactam, or vancomycin for MRSA, plus gentamicin for 2 weeks, plus rifampin for 6 weeks.
Bone and joint infections.
Duration varies, maybe 4 weeks for simple hematogenous osteoarthritis in kids. In adults, treatment is often more prolonged. Chronic osteo needs surgical debridement plus antibiotics. Septic arthritis needs repeated aspiration or arthroscopy. For prosthetic joints, especially if they can't be removed, combination of rifampin with ciprofloxacin has been used successfully, possibly due to better biofilm intracellular penetration.
Skin and soft tissue infections.
Archaeans.
SSTIs.
With CA-MRSA so common, you need appropriate empirical therapy if it looks serious. Even small abscesses appear to benefit from antibiotic therapy in addition to incision and drainage. Drainage is always key. Oral options include clindamycin, trimethoprim sulfamethoxazole, doxycycline, linezolid, tedazolid. Parenteral therapy for more complicated cases.
Toxic shock syndrome. TSS.
Mainstay is treatment of shock fluids, pressors, remove tampon spacking promptly. Antibiotics, expert opinion often favors combination of clindamycin and a semi-synthetic penicillin, or if MRSA, vancomycin. Clindamycin is key because it reduces toxin production. Linezolid might also work this way. The penicillin vanc is to clear any infection focus and prevent recurrence. 4V immunoglobulin benefits are uncertain. Glucocorticoids not recommended.
Other toxin-mediated diseases?
Food poisoning, entirely supportive. SSS anti-staphylococcal therapy targets the primary site of infection to stop toxin production.
And looking ahead, non-traditional approaches.
Yeah, lots of research here, developing new antibiotics, but also new and non-traditional approaches like use of phages or phage-derived peptides, bacteria-killing viruses, probiotics, and antivirulent strategies that disarm bacteria instead of killing them. Very exciting area.
Finally, let's talk about prevention. How can we, as a society, as individuals, reduce the impact of these pervasive bacteria?
Good question. Primary prevention in hospitals starts with the fundamentals. Hand washing and careful attention to appropriate isolation procedures. Seems basic, but it works. Several Scandinavian countries have been remarkably successful at preventing MRSA spread in hospitals through careful screening and strict isolation practices.
So basic hygiene and isolation are powerful. What about more targeted strategies, like trying to get rid of the bacteria people carry?
Right, decolonization strategies. Using universal and targeted approaches with topical agents, for example, malburicin, to eliminate nasal colonization and/or chlorhexidine to eliminate colonization of additional body sites. These have been successful in some clinical settings where the risk of infection is high, like ICUs.
Does it help with surgery?
Analysis suggests yes. Decolonization can reduce the incidence of post-surgical infections among people nasally colonized with S. aureus. Also helps prevent recurrences after discharge from hospital for S. aureus bacteremia. The risk of readmission is high, around 22% in 30 days, and decolonization following discharge with mupirocin and chlorhexidine can lower the incidence of recurrent infections.
What about bundling interventions?
Yeah, bundling medical interventions, applying selected steps in a prescribed sequence has reduced rates of nosocomial infections related to procedures such as insertion of intravenous catheters, where staph is a common culprit. It's about standardizing best practices.
And vaccines. Any luck there?
Immunization strategies have been tried, active vaccines, passive antibody approaches, but so far, none has been successful for either invasive or complicated S. aureus infections in clinical trials to date. Developing an effective staph vaccine remains elusive.
What about preventing recurrent infections in the community? Those are tough.
They are often difficult to treat. Strategies involve intranasal mupirocin and chlorhexidine washes for the individual, plus additional decolonization of household members combined with environmental cleaning, reducing the overall bacterial load in the home environment.
And that home remedy, bleach baths.
Yes, for individuals with extensive skin disease and recurrent infections, using bleach baths, for example, 1/2 cup of household bleach in a half-filled bathtub, 15 minutes 3 times weekly may be useful. Seems to help reduce skin colonization significantly. Low-tech, but potentially effective.
So wrapping this all up, what does this entire deep dive mean for you, our listener? We've really journeyed through the intricate, often startling world of Staphylococcus. From its microscopic identity, its cunning ways of causing disease, to the diverse illnesses and the complex evolving strategies for treatment and prevention.
Mm,
You should now have a detailed understanding that goes way beyond the headlines, putting you firmly in that well-informed category, ready to grasp nuances others might miss. The adaptability of staph and our ongoing fight against it really highlight the dynamic nature of infectious diseases.
absolutely. And if we connect this to the bigger picture, it's clear that while S. aureus and its relatives pose huge challenges, our evolving understanding of its genetics, virulence, resistance, combined with innovative diagnostics and therapies, definitely offers hope.
Right.
It also encourages us to keep questioning, keep learning, keep adapting our strategies against these persistent pathogens. Which leads to a final thought. Considering S. aureus's history adapting to basically every new antibiotic we've thrown at it, what might be its next major evolutionary leap? And how might those emerging non-traditional therapies like phages or antivirulent strategies be our best, maybe even necessary, defense for the future?
That is a powerful, maybe slightly unnerving thought to leave you with. Underscores how this battle continues. Thank you so much for joining us on this deep dive into staphylococcal infections. We truly hope you feel incredibly well equipped with this knowledge, hopefully feeling like a master of this complex topic now. Until next time, keep learning, keep questioning, and stay curious.